A very good morning to all of you. Here we are coming with VGM case capsule number 4. Hope you are enjoying our series. So this is a patient whom we've seen in this last week, a 50-year-old gentleman who was brought from a rehabilitation center with significant alcohol intake for the past 10 years. He had a binge intake in 1 week, heavy intake, and he presented with confusion and disorientation since 1 day. There was no history of fall. This is very important in alcohol patients to ask for history of fall. Previous history of alcohol withdrawal seizures were there on and off since 1 year. And the last episode was in February 2021. He was also smoking and consuming tobacco chewing. On examination, he was totally disoriented. He was bizarre, disoriented to time, place, and person, agitated, moving all limbs. He was obeying commands. He had icterus. There was no pedal edema. He was in a tachycardia. A BP was slightly elevated. Otherwise, he was all right. You know, some of our patients, we also see fever also. Okay, so the lab reports where we were talking about icterus. Yes, he had some rise in bilirubin and SGOT more than SGPT, which is the pattern we see in alcohol. And GGT was elevated and albumin was normal, probably indicating that he didn't have that much of a severe cirrhosis underlying. And INA was normal, again, a synthetic function of the liver. Why is this very important? We must know if the underlying liver is normal or having cirrhosis. Ammonia was 211. Again, I'll explain about that. And hepatitis B and C were non-reactive. We do it because he had icterus, but of course we know that the jaundice is because of alcohol intake. And total cholesterol was elevated and LDL was slightly elevated. TFT was normal. Ultrasound abdomen showed a fatty liver. So the DD for alcohol withdrawal syndrome, Wernicke encephalopathy, hepatic encephalopathy, head injury. Please keep these three in mind when you look at such patients. So how does alcohol withdrawal present? Initially, if they can have this, most of them will have this kind of minor tremors where they'll have just the shakes. It'll go on from second day onwards up to it'll just go on. Then alcohol hallucinosis with they'll be talking about weird things, and that also starts around the same time. And alcohol withdrawal seizures also happen the same time. You can see that pattern. The third day on or the 48 hours later, they can develop delirium tremens, which is a severe form of alcohol withdrawal. So if you look at this stages, mild, moderate, and severe, mild, they'll have anxiety, tremor, insomnia, headache, whereas in moderate, they'll have all the sweating and all the BP changes, tachycardia, tachypnea. Delirium tremens is the severe form where they'll have moderate symptoms, disorientation, impaired attention, visual and auditory hallucinations, and seizures. So what are we going to treat this with? So the main form of treatment is benzodiazepines. And what are we going to use? Chlordiazepoxide, diazepam, lorazepam. So lorazepam, we definitely for cirrhotic patients, we should not give long-acting benzodiazepines. That is why it's so important to know if the underlying liver has cirrhosis or not. Of course, every person who consumes alcohol at least for 10 years will have some form of fibrosis going on. Right? So we can never be sure. We should always be on the safe side and look out for it. And anticonvulsants, not recommended routinely, but if they had history of seizures in the past, after withdrawal, it's better to use it. Levetiracetam is also a safe option. Baclofen is a drug we give for a long term also. Our psychiatrist prescribes it long term for abstinence. And beta blockers, alpha-adrenergic, less often used. Withdrawal seizures. So very importantly, these seizures can happen in 15% of patients. That's very important. And we must know if there's no head injury. Please ask for that, look for that, suspect it. If there is any focal signs, please think of head injury also. Wernicke encephalopathy. Now, this is a very interesting thing. The best part is one patient can have all things together. He can have Wernicke encephalopathy, he can have withdrawal, he can have encephalopathy, hepatic encephalopathy. So sometimes you cannot differentiate. But the general diagnosis of Wernicke encephalopathy is Kane criteria, where there is three things. One is altered mental status, oculomotor nystagmus, and ocular ataxia. cerebellar dysfunction, and they will have some diet. They would not have eaten, consuming alcohol, not consuming food. Most of them will be like this, and it's in 17% only. You can see this triad, otherwise it's difficult to differentiate. Important treatment is thiamine, and before thiamine, it's important to give dextrose, because of, go back to biochemistry and see why. Always dextrose first and then start thiamine. And Korsakoff syndrome, these are all later things. These are not acute stuff. Korsakoff syndrome, how do they present? The patient will talk one real fact and one real fact. In between the two, he would have just fabricated his own, he'll have memory lapse and he'll fill it with his own confabulation. That is Korsakoff syndrome. And most important, hepatic encephalopathy. When are you going to suspect? Underlying cirrhosis is there. And if they stop consuming alcohol a long time ago, still they're present with something like altered sensorium, it's more likely to be hepatic encephalopathy rather than withdrawal. And they'll have a flapping tremor, asterixis. Ammonia levels may be high, but they are not reliable always. And of course, there can be an overlap. If any doubt, please give lactulose enemas to the patient. This patient, we just kept NPO, and we have seen withdrawals going on for a week or so. This patient had it like 48 hours. We gave dextrose, thiamine, lorazepam, lactulose enema, anti-seizure medication, and potassium correction and supportive measures for this particular patient. And because he had some potassium, low potassium, like 2.5, I think, afterwards. So the main thing is, electrolytes is also important, and to see if they are in sepsis, if they have underlying cirrhosis, all that is very important. And gradually he improved, consciousness became better. Very important. Why am I talking about sepsis? They can have aspiration pneumonias because of their inebriated state. So please look out for this. I hope this was very useful to you all. Thank you very much.